Hello, everyone. I'm Barbara Ham-Lee. So why is it that Hampton Roads has the highest rates of breast cancer, prostate cancer, and HIV/AIDS in the Commonwealth of Virginia? Why is it that African Americans are most at risk? What is it about this area that is affecting our health? And more importantly, what can we do about it? Up next on Another View, Dr. Lauren James joins us to talk about how where we live can affect our health. What's your zip code got to do with it? We'll tell you. Another View with my co-host, cardiologist Dr. Keith Newby. It's coming up next, so stay tuned.
Discussing today's topics from an African American perspective, this is Another View.
Hello, everyone, and welcome to Another View. I'm Barbara Ham-Lee. A couple of community notes before we talk with Dr. Keith Newby and Dr. Lauren James about healthcare inequities and social determinants that affect our well-being. I have two events to tell you about. Tidewater Friends of Foster Care invite you to the annual Foster Care Aware Block Party. It's from 1 to 4 p.m. on Sunday, May the 5th at the Harrison Opera House in Norfolk. May is National Foster Care Month, and this event celebrates those who support youth in foster care and has information on how you can become a foster parent, become involved in advocacy, or volunteer your services. It's free and it's open to everyone, so bring the family and enjoy. For more information, please visit tidewaterfc.org. tidewaterfc.org. And the Tidewater African Cultural Alliance presents a panel discussion entitled Mental Health Stigma Within the African Community. It's Saturday, May the 11th from 2:30 to 4 at the Greenbrier Library on Valville Parkway in Chesapeake. Donations will be accepted in support of the National Alliance on Mental Illness, Coastal Virginia chapter. To register, go to TACA-mentalhealth.eventbrite.com. So that's TACA mentalhealth.eventbrite.com. Just some things happening in our community to take care of our health. So what does our zip code have to do with our health? Why does it predict everything from our socioeconomic status to what we eat to how long we live? Joining us to talk about social determinants that impact our health is Dr. Lauren James. She's the director of the Portsmouth Health Department. Dr. James, welcome.
Welcome. Thank you for having me. I'm very happy to be here.
So excited to have you here with us. And my favorite co-host always of Another View on Health, cardiologist Dr. Keith Newby. How you doing, Keith?
I feel good now. You gave me a great intro.
Yes, absolutely.
Thank you.
Oh, you're very welcome. So we've talked about this before a little bit in the past, but we kind of talked about it on a more national scale. And since you, Dr. James, are right there in the heart of Portsmouth, you guys did a study fairly recently, and let me see this for just 1 second, fairly recently where you found out things like 47% of respondents to the survey had high blood pressure, 42% had high blood cholesterol, diabetes was 21%. You know, these are diseases that really impact the African American community. And you take it a step beyond just the health of it to actually what's happening in our lives to keep us unhealthy. So let's talk about what exactly social determinants means.
All right. So in public health, now we are calling it more so moving towards population health.
Okay.
But we're focusing on social determinants of health, your income of your community, education, level of disability, affordable housing. These are all systems that are in place that can determine your health and determine if you have the healthier options available. So it's a really big deal not to just say someone is unhealthy and they don't want to be healthy. More so it's, do you have the support and the resources in your community to make it accessible for you to achieve health?
Because the ultimate goal is for everybody to have health equity, not health equality.
Right.
What's the difference?
So health equality is everyone having a bicycle. Health equity is everyone having a bicycle that works. So if you're a smaller person or if you're a child, if they give me and a child the same bike, we're not going to make it the same way. Or if you have a disability and you're given a regular bicycle, that's not going to work. So that's what we are striving now. And health inequities are built on top of social and economic inequities.
So give us some examples of some of the things we're talking about in terms of health inequities.
Health inequities are being in a medically underserved community, being somewhere where there's a food desert. In Portsmouth, per se, there are 11 grocery stores. A lot of people have to walk a mile or two to get to a grocery store. So if you have young children, don't have a car, that is very hard and not accessible. Another example would be affordable housing. There's a statistic. In Portsmouth, about 50% of the residents spend 30% of their income. And this is from GHR, Greater Hampton Roads Connect. They have a lot of good statistics about health and social status. So if 50% of your community is spending 30% of their income on their rent or their housing, what's left?
Right.
What's left?
And most of the time, they probably would not have health insurance, and which would be another deterrent to keep them from going in to get help. 440-2665 or 1-800-940-2240 are the numbers to call. We want you to get involved in this conversation in terms of how you think about your overall health and the factors that affect your overall health. Dr. Newby.
One of the things from you looking at the list of the multiple, I guess, disease processes, and I don't know that I see it up here, but I would almost guarantee you one of the trigger points for a lot of these is obesity. Because that typically would always lead to the high blood pressure and the high cholesterol and the diabetic history, which leads to heart disease, which is where I come in, or shouldn't be coming in, but in any event. So, but all that is part and parcel. And you talk about the food desert part where you have convenience stores in a lot of these areas where the food choices are quick items that
I think it's about a third of our community has diabetes and obesity.
Yeah, so
you're correct.
There tends to be where they all correlate in the same kind of mix, and then the food choice. You talk about having a food desert, which there are many of. If you go to most, especially African American communities, you won't find many grocery stores there.
There's a stat here from the report, and the name of this report, by the way, is the 2017 Portsmouth Community Health Survey using Casper methodology. And it says 14% of Portsmouth residents report eating no fruit.
Yeah, I could believe that. A lot of it is just access, and some of it's just understanding what are healthy food choices, and sometimes the easier approach, we're living in this world of convenience and ease of access, so if it's easier to pull something off of a shelf that is, you open up a package and you eat it, they'll say like on a package and some healthy something, and it's not really healthy, but it's marketing issues, and you're thinking you're doing right. And I have tons of people when you really kind of dig down, when you talk to people about their health and their choices. Like I had a patient not even yesterday who we got into a little discussion about weight, and she was saying, I just can't seem to lose weight, and I think I'm doing everything right, and we started our debate point, and I said, well, you can't gain weight unless you're eating wrong, and we go through these debates about that, but then when you dig down and you start asking, tell me an average breakfast for you, and they'll say oatmeal, which is instant. They'll say, and they put bananas and raisins and all this stuff in there. I'm like, do you know how many calories that is in and of itself? So when you start really hitting them up with that, then they'll think they're doing something that's good for them. And they really do believe they are, but they're not.
But let me ask you, Dr. James, because I think a lot of people think when we talk about social determinants and we talk about inequity, that we're talking about poor people, that we're talking about people who are in disadvantaged neighborhoods. But for African Americans, you can even be middle class and upper middle class and still face health inequities. Is that right?
Yes, that's a very good point you brought up. Actually, April is Minority Health Month, National Minority Health Month. So,
this is perfect.
Yeah. So, a couple of weeks ago, out of Richmond, Virginia Department of Health set up a forum about Black maternal child health. So, basically, Black women are, I think, like 3 times, I don't know if that's the exact stat, more likely to die during childbirth.
Yes, it is. Actually, we did one recently.
Yeah, that's regardless of your income and or your social status. So you are correct. And a lot of it, when I was going to medical school, we were taught that, oh, well, Black people might not have the healthiest eating habits, things like that. But a lot of times when we go get treatment, we don't receive the same standard of care. Minorities may not receive the same standards of care. So it is not always on that population. It could be, how are they treated when they go to access care? Are they in a medically underserved community? Are they in a situation where they have transportation? Is it a walkable community? Is it a safe community? So many factors play into.
So then, Dr. Newby, then it seems to me we need to hold our politicians accountable also in terms of like the planning folks and all those, because if you go into certain communities, you're right, there is nothing but convenience stores and ABC stores and everything except a grocery store.
I know you hate to say that these are inherent of institutional racism, and you always hate to use those terms. It's just as hard to ignore the obvious that there is a bias towards certain neighborhoods. Because if you go to 20 neighborhoods that fit certain criteria in terms of who lives there, but you see the same type of stores there, it's hard to think anything different. And that's the problem that we see. Or, you think about cost of those healthy food items, which for the most part, you can find healthy items that are cost effective, but it's just more difficult than it is to, when you look at it, going to like a McDonald's and getting a dollar value meal, and you get all this stuff. You're like, well, I need to feed my kids. And you give them that kind of stuff, and then you're wondering why 5 years later they're 100 pounds overweight. Some people have to do what they have to do because their jobs won't allow them to make enough money to do other things. So it's a vicious cycle.
And what about the whole idea of the medical community and in broad strokes, kind of blaming the victim? In the sense of, like you and I were talking, Dr. James, prior to the show, about if you have to get a colonoscopy, and what were you taught about that?
I was saying when you are in private practice, you get metrics about how your patients are keeping up on their preventative care. So working in an underserved community, my metrics weren't great for preventative care. But within the community I was working with, we didn't have a mammography center. We didn't have a colonoscopy specialist. A lot of our patients take the bus. So it's not that they didn't want to get these things done. They just weren't easily accessible.
And that's a big problem. You really think about it, because if you don't have access to get these tests done, or like you say, if you have to cross town, I had a patient yesterday, again, I hate to keep bringing about yesterday, but had to take
had a day yesterday.
Oh yeah, three buses to get to see me.
Wow.
And and then she got there late, but then my office staff was asking me, well, because she's an hour late, do you want to see her? And I'm like, well, if she took 3 buses, how am I going to tell her no? I said, she can't help how the buses run. I said, those are things you can't always help. I said, no, let her come on in. But that's the kind of thing that you do see a lot of, is just access and the ability to get those things done. If you don't have a mammogram center nearby, and you'll get people with like that who just, they feel a mass, but they don't know where to go or what to do.
Well, I was going to say the education piece also. Are we assuming that everybody knows that they have to go get a mammogram, once a year or once every 2 years or whatever your age? I think it depends on your age.
And I don't know if everybody remembers, but like in 2012, Portsmouth was #1 for mortality of breast cancer in the United States, and they got a large grant. And
did that move the needle?
It did. But what happens with grants? They're great, and then they sunset. So, we're working now to build up our breast cancer task force, because those numbers are now trending upward. And actually, in Portsmouth, we're above average for our screenings. I think we're around like 60-70%, which is about on par with Hampton Roads. But now we're noticing that the continuum of care, people don't know where to go. People tell me, my primary care doctor treats my breast cancer. That's a no-no. Yeah. I'm family medicine. I want you to have the best care. I cannot treat your breast cancer. I can let you know where's the best place to go. So a lot of that stems from, in Portsmouth, we are diagnosed with the late stage cancers that are more likely. Because
people take so long to come and get help? Is that what it is? Some of that,
but it's just some of the late stage cancers is not a good prognosis regardless. So we're really trying to figure out, besides getting mammograms, how can we let people know that when you find these masks, this is how we're going to get you to care, and this is how we're going to follow up.
Or even to know how to do a self-breast exam.
Right.
A lot of people are not really clear about that, or to know how to look if you're getting past a certain age, about like even look at checking your stool for blood.
So what do we need to do to start to make sure that everybody gets educated? I mean, do we need a massive campaign? Do we need?
Well,
what do we need to do?
well-
Because sometimes we say, well, let's put information in the doctor's office. Well, if you're not going to the doctor's office, you're not going to get the information.
Well, I think some of it's a several part issue, but one part is in the federal government has actually been pushing this issue of this patient-centered medical home thing we unfortunately, so there's a lot of issues on that preventative care that's not always kind of followed, because it's hard with some patients, because number one, you got to get them in.
Okay.
And like they'll miss their appointment 800 times, and you keep trying to get them back in, and by the time you finally get them in, you forgot about all the stuff you need to do because you had so long to get them back, or you set up a follow-up, or you set up a colonoscopy or a mammogram, then they don't get it. Then you have to try to track them down to figure out why they didn't get it. So you have a lot of that you have to deal with, as well as trackable issues. So there is movement, I think, and correct, please, as family practice, you would know better than I, to try to promote that and to get people healthier. But you have to get people engaged. Patients have to want to get that healthy
So both
lifestyle.
of you are doctors. What are you hearing people say about why they don't want to get healthy? I'm
I'll
really
let you
trying
answer
to.
some of that one.
No, seriously,
I mean-
but I'm really trying to understand a mindset. And we're talking specifically about the African American community, but we're talking about people in general
I would
who
say
don't want to get healthy. Why is
what
that?
I've seen is with people who are lower income, scarcity, tunnel vision, focused on today.
Yeah.
If I'm just fighting to get through today, like you said, we're getting a doctor's appointment.
Yeah.
If I'm just fighting to get here, and this is a good day, that's what it is. It's the short-term mindset that you have when you are so limited in your resources. And then in the maybe middle class and things like that, it's more so ideas of how you're going to be treated when you show up. Are they a trusted resource? So that's a big thing we're doing with the health department, is becoming a trusted and consistent resource and engaging our community so that they know they can come to us.
And I'll tell you, a big factor is pain and fear of pain, meaning that I'll have people that will, if they got to get on a colonoscopy, they scared it's going to hurt. They don't want
But
the
they put you to
IVs.
sleep.
But the bottom line is that fear of the unknown.
Yeah.
If you've never had one before,
Right.
and I'm going to tell you, unfortunately, so some of the worst advice givers are so-called friends. I hate to say it, but I've heard people telling patients, like, don't take that drug because it's gonna kill you. No medical degree whatsoever, no understanding of physiology, pharmacology, nothing. But they'll sit there and make these kind of grandiose statements and have patients stop drugs.
Do you think the
hypertension
media,
drugs.
that because of the advertising of a lot of the drugs now, does that add to it, or
Well,
is
I don't know.
been
It
just,
could, because if I listen
if
to
you
those
listen to the
commercials, I don't want to take it either.
Well, I
They
was gonna
cause
say-
every possible side effect.
It's really interesting because, as I'm going through a family member who's ill now, and just listening to the side effects that the doctors, tell me. But something you said a long time ago, Dr. Newby, and you said even if it's 1%,
They're going to report
they
it.
have to report it.
Yeah.
And so you got to keep it in perspective.
Well, I tell people all the time, just because a side effect is listed does not mean you're going to have it. And that is, I get people, they'll read a side effect, they just assume they're going to get it. And I say, these are, don't misunderstand, but I blame the pharmacies for some of that, because in their sheets they give, they don't specify these relative risks. They just list
They
them.
just list them, right? So you don't know whether
Yes,
it's
you
in
don't know-
order
exactly.
of
And
what could happen
it
to
could
you or
be
not.
It could be a 5% risk. It could be a 0.1% risk,
Right.
but you don't know. And unless you as a doc kind of clarify that with these patients, but you don't even know that they're getting that stuff from the pharmacy. After years of experience, I know.
Mm-hmm.
So when they say something to me, I would try to, ward it off by saying, listen, let me tell you now, you may see a document that may say A, B, C, D, E. let me give you my take on it, and you kind of go through it. I mean, you try to educate them as best you can. But that's a big thing, is the fear factor. You'd be surprised how much that plays into this. And it is so prevalent of people saying, if I wish it away, it will go away. That something hurts, like they have a cough and they see blood coming out, it'll go away. And they don't want to know they have cancer. They say, if I ignore it will denial
makes it better.
You'd be surprised at how much of that goes on.
440-2665 or 1-800-940-2240. How much does the history of using African Americans in terms of testing, and I'm talking about like Tuskegee and others, because I know people today who will not take a flu shot, for example.
Yeah, I know.
And it actually started in slavery. Some people would let other physicians operate on their slaves, and anesthesia didn't exist then, and they would put them back to work. Yeah. So it's a long history, and I think some of the remnants are there, even if people don't know why they're mistrusting. And I think John Hopkins had a lead issue.
I think it travels generation to generation. If you really think about it, it's something that happened 5 generations ago, and they tell their children.
And their children,
tell them, and it's just an inherent mistrust. But she's right. And if you talk to my sister about that, sometimes she'll tell you she just because of her background. She and I had that conversation. I didn't know about how they would just do things without anesthesia, just to see what our pain threshold was. You get an amputation or something like that. I mean, so you can understand to a degree how that can come into play.
And I think a lot of it is asking the right questions. We have to, take our part too. Are we asking what's the purpose of this? As educated people today, we can ask, what's the purpose? What are my options? So being our own advocate is the solution. And I like what Dr. Newby said about your friends. My patients would much rather listen to every single friend they have besides me. I am not a friend, I guess. I think I'm a good friend. But, the point is, now at the health department and a lot of other health departments, we have what we call community health worker. These are citizens, community members that may or may not have a medical background, that are trained to know a little bit, but to kind of help people go in the right direction. Hey, you want me to come to your doctor's appointments with you? You said you don't understand any of your prescriptions. And say, hey, doc, they really don't understand what you're saying. Do you have somebody, a nurse that can take a little more time? So sometimes things like that help, but not everybody can, access that resource yet.
Right.
But that's one,
But that's one of the solutions that you're working on, which is great. 440-2665 or 1-800-940-2240. LaVon joins us from Norfolk. Hi, LaVon, you're on the air.
Hey, Miss Lee, how are you?
I'm great. How are you?
I'm good. I was just listening, and I think everything that was said was very relative to where I live. I know you know Miss Lee, but my name is LaVon Pledger. I'm a resident in the St. Paul's area. I'm a certified personal trainer, and I know what it's like to be in an area where health literacy comes very scarce, and people just don't have the scope of, what's going on around them and how to, live healthier. We do have some access to, open door projects and things like that when it comes to care and receiving certain benefits, but living that day-to-day struggle in an poverty area is very hard for a lot of people. And that focus of wellness, that whole wellness aspect is different from my community as it is 2 blocks up the street, where they have a life expectancy of 12 years more than what we do. Or in Virginia, actually, if I'm not mistaken, WIC did a study maybe 4 years ago. Virginia has the highest number of childhood obesity in the country at 20%. That's 1 out of every 5 kids in areas like mine are obese and suffer from chronic illness. And I'm trying to, as much as I can, to, bring health literacy, exercise, fitness awareness, nutrition awareness into my community, because I think it's very, very important. just the quality and quantity of life.
Absolutely. And Levon, we know he has a fitness program and he goes out, works out in the parks, talks to residents, and really does a really great job in terms of trying to educate. Levon, thanks so much for the call. We appreciate it. Is that part of the solution that
Yes.
we're going to have to find advocates within the community?
Yes, Levant is part of the solution because people will listen to him if this is a community he lives in and cares about, and just, trying to make the healthier choice the more accessible or easy choice. Ultimately, that's what we want to get to as a society, to have those things in place, because if you don't have your health,
you don't have anything. Absolutely. If you're just joining us, we're talking about equity in healthcare with Dr. Lauren James, Director of the Portsmouth Health Department, along with my co-host of Another View, cardiologist Dr. Keith Newby, who now has to leave us because he has a very important meeting that he has to run off to. So we'll let you say goodbye.
Well, thank you very much.
And we will see you next month. And Dr. Lauren and I will continue the conversation.
And, miss me a little bit.
Yeah, we will miss you a little bit. We'll miss you a lot. We'll be right back. Okay, and we're back with Dr. Lauren James. She is the director of the Portsmouth Health Department, and we're talking about solutions to health inequities as well as the social determinants which determine how our health is going to be. Let's go to Pam in Yorktown. Hi, Pam. You're on the air.
Hi. Just wanted to bring up anecdotal something. My
Sure.
mother-in-law, when she was in her 90s, she since passed away, but I would take her to the doctor, and the doctor would explain what needed to be done, what she had to do, everything. And she'd smile and say, uh-huh. I learned to say, okay, what did he just tell you?
Mm.
And then there would be silence, and then she'd say, well, maybe he better tell me again.
Mm-hmm.
I don't think a lot of doctors are trying to get feedback from the patients to ensure that the patient understands what they've just told them.
That's a very good point, Pam. Thanks so much for the call. That's another way that we need to look out for our elderly folks, because I know doctors are busy. You're busy. You got 12,000 people standing, in the waiting room waiting for you. But sometimes people don't understand and they're too afraid.
Yeah, I agree. The caller brought up a good point, and that doctor may not know your mother like you know her. And so you could tell she was going through the motions, whereas you were there to also advocate for her and make sure that she understood. So I think she has a point, and, a little bit of it's on the patient, their support system, and the physician to make sure. But that's some really good insight, and making sure, especially with our elderly family members or maybe not as high educated, to go with them, to advocate for them, to make sure they are understanding what happened.
And, we were talking about this whole advocacy thing anyway for patients as we look at solutions, because one of the things you and I talked about, Dr. James, was that we wanted to talk about what can people do where they are right now in terms of making a difference in their health, regardless of their zip code, regardless of their socioeconomic status, regardless of the things that could be holding them back. And so is advocacy one of those?
Yes, I definitely think advocacy, I think we use the term education very loosely, but I would say just like every community has its assets, even if it's the poorest community, there's an asset. Every person has their own assets. So building from that and just realizing that you have buy-in for being healthy and you have to be accountable for that. So really acknowledging and being aware of the role that you play in your own health, and then working with your physician or whomever as a partner, and then advocating for your community for things you want to see, being an influencer for policies you want to see, for having a safe neighborhood, for having schools open that you can walk around after hours, things like that.
So, we had a caller, Beth, who had to, who couldn't stay on the line with us, but she wanted to know how patients and providers can work together in shared decision making.
Yes, I think that's a very good question, because a lot of times as physicians, we know what the standard of care is and that's what we want to push. But we also have to know that this is a person. What are they comfortable with? What are they, how do they want to move forward? What do they deem as quality of life?
And if there's a true partnership, then as we try to overcome some of these inequities, if the healthcare person is aware of a patient's situation, might they prescribe something a little different for that person? In other words, still can get to the same conclusion, but maybe they don't have to go with the name brand drug, or maybe they don't have to require them to come back as often, or things of that sort.
That's a good point. And I think they just had like a report on it the other day about prescriptive nutrition. And I think in Chesapeake, they're doing something with that now, where they have a medical hub where in general, if you have certain illnesses or diseases, they prescribe certain nutritional things. So that would be an example. If you have a patient who doesn't want to take any medicine, if you really know the nutritional aspect, or you can set them up with a dietitian. In some cases, that can be very successful, but it has to be a very engaged patient.
Very much so. So what else can we do in terms of changing some of our habits and become more healthy?
So I definitely think the first part is being an advocate and understanding for your age group what's expected for your preventative care. Is that an annual exam? Are you 50? Are you getting mammograms, your colonoscopy? So having that yearly check-in with your physician, even when you don't have any medical illnesses, because it's much funner to go to the doctor when you are not sick. And so then when you return and need that doctor, he knows your baseline. It's not like you're showing up, and everything's always horrible. They want to see you when things are going good. So you all have that. That goes back to relationships, and also having a physician you trust. So a lot of times I would send patients to specialists, and it just wasn't a good dynamic. And that's okay, because, relationships are different. What I look for in a physician.
So is it okay for a patient then to call you back and say, Dr. James, you sent me to Dr. XYZ, and we just didn't click. Can you send me someplace else?
Yes, I'm totally fine with that. But I will reiterate, because most of the referrals I do are to people I trust and routinely work with in the community. But I will reiterate why I trust this person and my relationship with them and how they are a trusted resource. Because you never want to, I feel like 99% of physicians are here doing it because they want to help people. And so you never want to put anybody down. But I would also, make a change in the referral to someone they might be more comfortable with, but to also set appropriate expectations. Because we are in a medically underserved community, so there might not be a whole bunch of options, and then that burden is on the patient with my assistance to go out
further
of our network. That may cost more, but if this is what you want, this is what we're going to make happen.
So we were talking earlier about prostate cancer, breast cancer, diabetes being high in Hampton Roads in this area. And a lot of that is related directly to obesity. But HIV/AIDS, why haven't we been able to conquer that yet? What's going on with that?
And
it's Black women, if I'm not mistaken, that there's been a growth.
So I'm not sure on the exact stats of which group it is, but across like Hampton Roads, Tidewater area, the rates of HIV are very high. And, we can't lump in, because if we even think about the Eastern Shore, that's a very rural community. So a lot of times it's stigma in smaller communities, because they know if you're going to health department, you're going for STDs. So they'll say, oh, Joe saw so-and-so. So I think in smaller, close-knit rural communities, that prohibits people from wanting to seek care.
So that's the only place that they would go in a smaller community, would be to the health department.
A lot of times, yes.
I really hadn't thought about that.
Yeah, so it could be something as small as that. It could be something worried about, if I do find out I have HIV because my partner has it, how am I going to afford medicine? But fortunately, with the Ryan White grant, everybody can get free HIV treatment through the health department. And we now have PrEP. That's the prophylactic medicine for high-risk communities.
How does that work?
So PrEP is a daily medicine. Truvada is the brand name that we give as treatment to prevent HIV in high-risk populations, such as men that have sex with men, people who are sexual workers, drug users. So there is a certain population that qualifies, but it's also, at this point, it can be given for reduced cost or free through the health department. So that's a really good resource, and that's the big push to prevent HIV.
And so I think a lot of people are unaware of exactly what the health department does. I mean, you think about private doctors in private care, private practice, you think about clinics, but what does the health department do?
We're just so awesome. We just care about.
Here's your chance to sell yourself.
I have to tell a funny story about my mom. So when I went from private practice to working director of the health department, mom was like, "You're gonna lose all your patients," and I was like, "No, now the whole city are my patients." So long story short, we do population health, exactly what we've been talking about, community engagement, helping be influencers of policy that creates productive change. I think there was a tobacco policy that passed this year about no smoking in schools, but took it to another level. I think it might have been at school events or on school property. Not exactly sure about all the details, but we are influencers of things like that. In our restaurants, we do health inspections to prevent foodborne illness, festival inspections.
So are you guys down at
Yamosha?
Down at the something in the water? Or would that be? I mean, in other words, since it's such a huge festival, would they call in more than just the Virginia Beach Department of Health?
If they needed backup, we would definitely. We always partner together. We also do bioterrorism. If there was a effort, you think about all the military and naval bases we have in this area. We work closely with them. If there was an event, hopefully never there will be one. But also we do. We have an epidemiology department. They follow and track our flu so we can gauge where it's at. We're happy flu season is over.
So it's officially over now.
And tracking foodborne illness outbreaks within the community. I'm trying to think. We also have a clinic. We do STDs and family planning and PrEP. Disease investigation is a big one.
So you were talking about the small communities, and if somebody goes in, there's a stigma attached to that. Is that the same in more urban areas if somebody's going to the health department?
That's a good question. Yes. In urban communities, often they will see people they know in the waiting room. So that's a big deal. Now you're seeing your partner and maybe their other partner. And so that's a stigma, but I think that's a little bit just like, just saying, okay, we're all here to be healthy now. We're all here to get treated. So kind of getting away from that type of thing. But I think it's a different kind of stigma in more urban communities.
So I was trying to see whether we have a call. Yes, we do. Bill from Newport News. Hi, Bill. You're on the air.
Hello. Yeah, you guys were talking earlier about changing doctors if you don't like somebody. I had an experience, and I just thought I'd share how easy it was to change. This family practice guy he got kind of, I don't want to say he got combative, but he got adversarial every time I asked a question.
Okay.
I just wanted information. So he took offense to it. In the meantime, he referred me to a urologist for another problem, and I went to the urologist and ended up telling the urologist about this other doctor, this family practice guy. And the urologist says, well, he said, I can recommend somebody for you. And so he did, and I started going to this other doctor, and that was back in 2013. I've been going to the new doctor ever since. So anyhow, I guess my point being is I wouldn't be afraid to tell, and both these doctors were from the same group. I wouldn't be afraid to ask for another opinion or another doctor.
Good. And you would encourage people if they have an issue to do that. Go ahead, Dr. James.
Because sometimes, and I think this is a learning point for physicians, when we have patients who are, like yourself, engaged and inquisitive, we can say, oh, they're threatening our knowledge. But that's not how we should take it. We should take it as, oh, they care. Let me inform them as much as I can and work with them. So it sounds like it just wasn't a good fit. Sounds like you found somebody who was a better fit. So I commend you.
Thank you, Bill, for the call. We appreciate that. Let's talk to Terry in Norfolk. Hi, Terry. You're on the air.
Hi, Barbara. Listen, I want to circle back to the question you just asked the doctor a little bit earlier about, how do you talk about the factors that contribute to disease, most significantly obesity. My concern is I'm getting older. I'm not African American. I'm white, and I have several diseases that can be directly attributed to my weight going up and down all my life. What I really would like to some people to think about, and if the doctor can solve it, she deserves to be a gazillionaire. Is no, we shouldn't fat shame. No, we should celebrate whatever. But there's no doubt that obesity contributes to lots and lots of diseases. And my concern is the whole body positivity culture is just ignoring that.
Okay, we'll talk about that, Terry. Thanks so much for bringing the point up, and thanks for calling us. Her whole point being, even though you should be proud of who you are, regardless of what your size is, that you really need to understand that there's an issue if you are obese or overweight. And the term obesity does not mean 500 pounds.
Right,
I mean, that is obese, but
yes.
it is a lot less than that.
Yes, correct. So I think she brought up a good point. I think we should love our bodies, but we should love them inside and out. So being confident with how you are, you should still try to eat and live a healthy lifestyle. No, I don't want anybody to be fixated on an exact number, but you should be eating so that you feel a certain way and so that you are taking care of your body and you are preventing chronic disease.
You mentioned before that the health department is advocacy is part of your work in terms of the government and so forth. As we look at challenged communities and we look at the lack of grocery stores and so forth, might that be an issue that health departments for the state could take up in terms of how we fix that issue? Because if people can't get healthy food, close by, it's going to be really, really hard for them.
Yes, that's a good point. And I think a lot of health departments are working on being influencers of policy and things like that. And what can we do locally? So I think that's a good point, because in a lot of cases, we can do what's called prescriptive nutrition, where changing your diet can, prevent, treat, whatever you want to call it, some of these chronic illnesses. So I think that's a good point. And we are working towards that. But it's, it's not a one size fits all.
Right.
Every community needs a different bit of plan. But I want to go back to how you were talking about the Something in the Water Festival.
Sure.
So that goes back to social determinants of health and how everything's interconnected. So actually, Pharrell Williams did reach out to the Virginia Health Department, and he chose to focus on how minorities are underrepresented in the bone marrow registry. So what that means is that when minorities get a bloodborne cancer, we have less options for treatment because we're not in the registry. So that's another inequity. I don't know if we're not comfortable being bone marrow donors, we're not comfortable giving our information. That goes back to, medical mistrust, things like that. But that was good that you brought that up, because by him focusing on that and integrating it in a bigger picture just shows how health is still important, even though we're here for a music festival.
Exactly.
We're here to be entertained, enjoy ourselves, but it's still important.
The other point along that line too, being an organ donor is something that we as a community don't do as often as we should. And then the other thing is the whole idea of drug testing. And I wonder how you feel about that in terms of people. A lot of times when it gets to the people phase to test out a new drug and so forth, it's rarely African Americans who are tested. So therefore, we don't know how it may affect us as opposed to other populations. Now, some people's argument is, well, we're all the same inside and we all bleed the same and so forth. But haven't we found with other drugs that there are differences?
Yes, we have. How we metabolize medicines, certain blood pressure medicines work better for African Americans. And so that's a good point. And it goes back to that relationship. So I think with patients that you build a good rapport, it would be easier to recruit them, because they would say, I trust Dr. James. I know her. I know she wouldn't give me anything her mother wouldn't take. Not 100% of people, but I think people who you are truly invested in. And I think a lot of times with these studies, they might not have that relationship or really explain it to the person. They might say, do you want to be in this study, and give you 100-page packet of, but really taking the time to explain how important this is to your community if you contribute.
And probably back to that fear factor we were talking about in terms of like the Tuskegee experiment and so forth. There's that trust factor of, I don't know quite, whether you're really giving me a placebo or
right. What are you giving me?
What is this going to do? So do you think it's important for us to be involved in that?
Yes, it is important to us to be involved, because if we're not at the table, how are our results or our how are our outcomes going to be gauged if we're not even participating? So I'm not saying everyone go join a study, but I'm saying if you're asked and it's something you feel comfortable with and you are well informed on, please be a part of that.
And participate in that. We only have a few minutes left. What about the children? Even if our health is not the best, should we focus then on our kids? And what do we need to be doing in terms of prevention for them, regardless of what our situation is?
So that's a very good point. And I think, keeping them active, whether it's in your community, at a local YMCA actually has discounts for those. It's kind of, it could be expensive depending on your income. And so keeping them active, helping them have healthy options. So, not always doing fast food or what's called frozen dinners, having fresh fruits and vegetables. And even if it's frozen, because fresh fruits and vegetables go bad quicker. That's why people on fixed incomes may not buy them. But I think it's really being aware of what can I do? So I can't do it all, but what can I do? Can't eat fruits and vegetables daily? When can I do it? Every other day. So really trying to tailor
that's a good point.
Those decisions to what you can do.
And you don't have to join a Y or you don't have to go to a gym. You can actually just let them go outside. But I get in some neighborhoods, the whole idea of your kid going outside to play is another social determinant that keeps us from being healthy because it's too dangerous for them to go out. But there are some things they can even do inside.
Correct. Yeah. So I think that's a good point. And you want to set that example. You want your child to know that you prioritize their health. And they also want to see you do it.
Exactly. So you can make that a family affair.
Yes.
So we've got about 2 minutes left. What would be a message that you would want everyone to walk away from in terms of social health inequity and also social determinants that keep us from gaining that equity?
Okay, so that's a good question. So I think that although we've discussed the health inequities that minority communities and rural communities face, we still have to look at these as opportunities. These are all things that can still be improved upon. And by educating and advocating for ourselves and our communities, ultimately we are the influencers. So we can't always depend on, the senators and the representatives if we are not advocating and telling them how important this is. How will they know? So I think that's a big thing. And also just realizing how important your health is, how you have to prioritize it. If you're not healthy, you cannot be productive at work, at home. You can't have time to be in your civic league if you're not healthy. You're going to have a shorter lifespan. Somebody brought up the lifespans in Portsmouth. Some communities, lifespan is 67, where some is 80.
Wow.
So,
Dr. Lauren James, who is the director of the Portsmouth Health Department, thank you so much
for
joining
having me.
us.
Thank you.
And we will be right back.
Hi, this is Essie Patha-Merkerson from Law and Order. You are listening to Another View.
And welcome back. While Grammy Award-winning artists deliver the music that thousands have descended upon Virginia Beach to hear, one local artist will be painting to the vibes during this weekend's Something in the Water Music Festival. Our Lisa Godley spoke with Clayton Singleton about what he plans to create and what it means to be a part of an event of this magnitude.
Norfolk native Clayton Singleton can be described as an artist, an art teacher, a poet, and a speaker. And he couldn't be more excited to be a part of this weekend's Something in the Water Music Festival. So I asked Clayton how all this came about.
Word is the curator for the visual art part, the art walk, B. Mike, he saw my work. And he was like, who's this person there? Why isn't he here? And we talked, and he explained to me what it was. And I said yes, that it was going to be murals up and down the art walk. And I would have an opportunity to create an 8-foot by 12-foot mural.
Clayton's artwork is being showcased in 2 different locations. The largest mural is already finished. It's titled You Are the Future of Love and features 3 young men, all art students of Clayton. Resting on a bright yellow and sky blue backdrop, In the bottom half of the mural is a city skyline, and it's currently on display at the corner of 17th Street and Pacific Avenue in Virginia Beach. But if you want to watch the artist at work, Clayton will begin his second creation for the festival Saturday at 2.
I'm actually performing painting on stage.
Okay.
For like 2 hours.
All right. Do you know what you're going to do?
I'm not certain yet. I want to kind of take the feeling of this inclusive, unified love. So I want to have that. And I feel like I want it to be partly interactive. So in my mind of minds, the people are also helping me paint it by telling me things. And then I want to include it into the piece. Give me your favorite phrase. And someone tells me something or yells something to me. And then I want to start to use that. And then a bit later, ask somebody else for something. I have a few things I want to include, but I want to bring other people in with it. Okay. So it's like it's our piece, just like it's our region, like it's our concert, if you will. So it's our festival. I want people to be a part of the piece that I do.
If you happen to miss Clayton's creative expressions this weekend, all is not lost.
They're going to stay up for like a little while, and they're going to move them to different places around the city. I don't know what the determination is in terms of how long they want to have them or use them, or how long they will last out in the elements with the sand and the wind and the sun. But they are very sturdily built, and the paints are all exterior type paints that should last for years and years and years and years. But I'm quite certain that you're going to be able to see them for a good while after these 3 days.
While this isn't the first time Clayton has painted in front of a live audience, he shares why it ranks as one of the most significant events of his career.
When I've done this before, it's been in front of a crowd, maybe 50 people, dare I say 100 at the most. And I was off to the side while the band played. I was an addition. I was something to see. This is different in the sense that I'm the focus for those 2 hours. I'm no longer the sideshow. I become the show, which now makes it more important. So I have to be hyper-focused, and I can't let them down because they're there to see this happen. This event that will really never happen again.
13 local artists were selected to paint murals for the festival. Each will get to showcase their skills live starting Friday afternoon and rotating every couple of hours. Clayton gets his turn when he takes the 17th Street stage with brushes in hand Saturday afternoon at 2. For Another View, I'm Lisa Godley.
And I've had the pleasure of seeing Clayton Singleton paint to music, and it is quite a performance. So if you are down at the Something in the Water Festival, go on by tomorrow afternoon at 2 and watch him do his thing. And we hope that you will use the information we talked about today and make changes to create a healthier lifestyle for yourself. If you'd like to hear the show again or share it with a friend, please visit our website, anotherviewradio.org, and download the podcast. You can also sign up for our eView newsletter. It's a once-a-week reminder of upcoming shows. We're on Facebook, and I'm on Twitter at Barbara Ham Lee. So next week on Another View, producer Lisa Godley is in the host chair with another stimulating conversation about things happening in the African American community. Our theme music was composed and performed by Jay Sennett. Lisa Godley is our show producer. Todd Washburn is our audio engineer, and Jimmy Cooper answered our phones. A very special welcome to Hampton Roads to all of you visiting us this weekend for the Virginia Tattoo and the Something in the Water Festival. Have a safe and wonderful time right here in Eastern Virginia. My name is Barbara Ham Lee. Thank you so very, very much for listening to Another View.